modify the therapy program to address specific issues of individual patients. We're going to switch now to the swallowing part of it. One reason speech-language pathologists deal with voice, speech, swallowing, all those things, it's like from here up is our specialty. And in voice with breathing and the vocal cords, and with speech with the oral cavity and swallowing, they all share the same aerodigestive tract in performing those functions. So that's our reason for including swallowing. The patients that come to me generally have some kind of symptom. Normally, we don't think about swallowing until we have a significant change in it. Sometimes we'll drink too fast or swallow too much food at one time, and we'll cough and we'll say, oh, that went down the wrong way. And in reality, it's probably what we call aspiration, where something went below the vocal cords and down to the airway, and our body's reacting to that function. The most common complaints I hear from patients that come in is, oh, I cough at meals sometimes, I cough with liquids, sometimes I have a choking feeling, or food gets stuck in my throat, different areas. Sometimes it's higher, sometimes it's down lower. I have excessive mucus, and I feel like that's holding up my swallowing, that's interfering with it. Drooling, sometimes drooling interferes with me being able to swallow my food and complete a meal. And then I have difficulty with my medications. I can't get my pills down. What can you do to help me? I had one patient tell me, well, I'm really having trouble swallowing my pills, and after further questions, he told me he was trying to swallow 3 or 4 at the same time. And I said, well, your first choice might be to just try one at a time, and then we'll look at some other things you can use. When a patient comes for a swallow evaluation, it's usually 2 parts. The first one is a clinical evaluation, where I take a history, I let the patient tell me what's going on when they're swallowing. That's usually the best picture for me to understand what's going on. We talk about their current diet. Do you eat anything you want? Do you avoid certain things because they're more difficult for you? You cough on them, you have a harder time getting them down. How do you eat? Do you eat fast? Are you slow? Does it take you a long time to complete a meal? Do you fatigue? You get tired of chewing? Do you drink liquids while you eat? Some people eat their whole meal before they ever take a drink of liquid. And we'll talk about that in a few minutes. Then, if a patient has really minimal changes that are occurring, we talk about some diet modifications that might be able to help. You know, drink more liquid while you eat your meal. Slow down a little bit. Repeat your swallow. Think about the textures you're eating. If you do cough, what kinds of things do you cough on? These are good things for you to be aware of and notice. It'll affect the progression if you do have a swallowing issue, which the medical term is dysphagia, in case you've ever heard that before. We also talk about some safety precautions to use at meals, and they're good for all of us. It's best to be sitting up and be alert when you eat. It's always better to eat a little bit slower than fast. It's good to have liquids while you eat. It's good to prepare your food for before you initiate the swallow. There's actually 3 parts to a swallow. There's the oral stage, and that's really the only thing that you have a lot of control of. You decide what you're going to put in your mouth, how big a bite you're going to take, how well you're going to prepare it before you initiate your swallow, whether you need a drink afterwards, whether it's going to take 2 swallows, and how much food you want to eat at one time. I'm too tired. I've had enough. I'm going to quit now. Then the second phase is a pharyngeal phase. I can't really evaluate that very well without the next procedure we're going to talk about. I can get some indications what's going on there, but we really need to do more evaluation before we make a decision, recommendations on that. And the last phase is the esophageal phase, where the food's transported to the stomach. So we're going to talk about the modified barium swallow study. And I'm going to show you a picture here. This is what goes on when you swallow. In a modified barium swallow study, it's usually done in a radiology suite. It's short, 15 to 30 minutes. The patient sits up in a chair with the arm around so they can take a recording. It's called a video fluoroscopy. And you're actually given some trials of liquid and food with a tiny bit of barium in it so that it shows up in the swallow. And we can actually tell how quickly you initiate your swallow, whether it's caught any of it penetrating down towards the vocal cords and the, maybe I can show you. I can do it from here. I'm not very good at this. Okay, so get my light going there. All right, so this is called the larynx, and the vocal cords, your airway to the lungs is in the front, and as Dr. Kamani or Dr. Chitnas mentioned earlier, we don't want anything going to the airway because foreign particles might eventually produce pneumonia, and which is not a good thing. So we want to keep things out of there. And generally, patients will cough if something goes into the airway. It may be delayed after the completion of the swallow. A few percentage of patients are silent aspirators. It can go to the lungs and they're not even aware of it. So swallowing becomes a real issue for them. If food or particles get hung, there's some pockets in the larynx, and if food, called a vallecula, and if food is hung up in there, it'll give you an uncomfortable feeling, like it's not really going down. Patients tell me they'll repeat swallows, they'll drink liquid, they still feel that hanging mechanism going there. A lot of times with MSA, there's a weakening in the pharyngeal muscles as well as in the oral cavity, and so the timing is off for the swallowing sequence. And that's why a modified barium swallow study is important. We can actually tell if there's a weakening there, if there needs to be a texture change in the diet. We usually try some different positioning techniques. One of the most common ones called a chin tuck. And you take a bite or a sip of liquid, you tuck your chin, you swallow, and you're closing off the airway, you're protecting it, and it's easier to control the liquids. Sometimes we'll try a different swallow technique, which is not so often. It might be effective, but it's difficult because it's not something you don't want to go through a special swallow when you're having dinner with family or out in a restaurant. So, but we do try those so we can actually see it on the fluoroscopy. At the end, the patient's allowed to watch themselves swallow. Family and caregivers use, one of them at least is usually allowed in there to watch while we do it, and it's a really quick test. If the swallow is functional, maybe just weakening, but it still works effectively, then it serves as a good baseline. And for MSA patients, we really recommend that they have it done every 1 to 2 years, unless they see some noticeable changes taking place, like more coughing or difficulties. Usually with MSA, the research says that, and I've seen it too in a lot of patients, most of the problems with swallowing occur in the oral phase first. And it can, later on, it can develop into what we call a tongue pumping, where they have trouble initiating the swallow. And you can see that on the fluoroscopy. You don't always see it when they're eating, but they have a difficult time initiating that swallow. The patient may tend to hold food in their mouth. And if a cognitive component's involved where they just get tired and fatigued, you might have to cue them to go ahead. Okay, it's time to swallow that. We got to finish eating. All of this ties into the amount of time you spend at meals. And even though I told you earlier to eat slow, you don't want to spend 45 minutes to an hour and a half at a meal. And so there's some alternative choices we'll talk about now. Let's go to therapy. Okay, so if therapy is indicated, if the swallow function is not completely normal when we do the studies, and patients still having some difficulties, there are several choices we have. The types of therapy things I mentioned to you are not appropriate for everybody. Not every patient's going to have all the symptoms I talk about. So we try and individualize it, what will meet your needs most effectively at the time we're seeing you. Dysphagia therapy usually includes swallowing exercises, maybe some positioning changes while you eat. If posture's poor, or do you need to use that chin tuck, or we have several other choices that we can offer you, then we work on those. Also, vital stim, I put that up there. Vital stim's not a cure, but it helps it's electrical stimulation to some of the pharyngeal muscles, and it's offered as a therapy option, and it's not very painful. I've done it. And you actually practice your exercises in different trials and different textures of food while you're having the therapy. The other thing we look at is diet modifications. I think an SLP wants you to be able to eat everything you like for as long as possible. I know that's what I'd want. So we try not to change the things that you really like, but ways to modify them. Maybe a softer diet, maybe smaller bites, cut up. If you're really a meat lover, cut that up really small, and serve softer items usually with sauces on it. Sometimes we need to change the liquids. Some patients just have trouble with water or tea or coffee. There's 3 different choices as far as liquids. There's thin, which is water, coffee, tea. There is nectar, which is a thickener, which can be added to your liquid. They call it nectar consistency. What we found in recent years is that carbonation, a carbonated drink, whether it's ginger ale or juices or carbonated water, actually has the same effect as nectar. The bubbles give the sensation of slowing down the liquid. We go to a thicker liquid because the muscles are weakening and they're not able to control the liquid as well as they were initially. Then the thicker levels are honey thick liquid and then pudding thick. We also look at how you eat. I mentioned this earlier. It's some of us, because we live in a kind of a fast environment, we've always eaten fast, and we need to learn to eat a little bit slower. The MSA patients do. It's probably good for all of us too, but we need to take our time, eat a little bit slower. Smaller bites. Alternate liquids with each bite of food. I know this is repetitious, but it's really important. And MSA patients, like I mentioned earlier, they tend to, alertness is really important. So if they tend to fatigue very easily in a meal, then it's best just to stop and look at smaller meals a day. Instead of 3 main meals where you're spending over an hour with the patient, then go to 5 or 6 small meals, little things that are still nutritious and keep up the hydration for the patient. I really am aware of weight loss in patients. I want them to have the nutrition and hydration that's needed to keep them healthy. So that's something constantly we ask about, particularly when we're working with dysphagia. Then the last thing on there is alternative means of nutrition and hydration. And that's when the swallow function is at a level where it's really the risk for aspiration is really high. It's probably can be supplemented in many instances by pleasure feeds for patients. It's important that you keep swallowing no matter, but you get your main hydration and nutrition from other means. Okay, so now what you can do as family and caregivers. We mentioned aspiration before, and in addition to being uncomfortable, swallowing changes are also may put you at higher risk for aspiration, so you need to be sure you sit up, not lean back and get too comfortable while you're snacking on those foods. Small bites, small sips, alternate bites of food and liquid, eat slowly. I like the next one, don't talk with your mouth full. I can still hear my mom saying that to me when I was a kid, and she had no clue why. Caution when drinking with a straw. When you're drinking with a straw, if you think about it, the liquid comes, you suck on it, the liquid comes much faster. With those weakening muscles, you have less control over the amount of liquid, and you're liable to get too much and not be able to control it. And then sit up after meals, 15 to 30 minutes. With some patients, it's even more necessary. It's necessary to sit up much longer than that. That's just a general rule of thumb for all of us. And also not on there is drink lots of liquid, whether it's for your swallowing or your voice or your speech. Water is good. Okay. And the last slide is some safe swallowing suggestions, a lot of them repetition, about eating and alternating. Repeat swallows. Repeat swallows are good if you feel like you have something hung in there, and it'll help get it down. If fatigued chewing, then you most likely will need to try softer things. Avoid those nuts and chips and tough things. Smaller meals are a good idea more frequently when the patient fatigues and gets too tired and you spend too much time. It's frustrating for all of you when you have to spend too long at a meal. So I want to hope this information's been helpful to you. In that the knowledge and education we can offer might help you look for signs when a problem might occur and know that you have some choices for treatment and how to care for it. Okay, thank you very much.